you everyone for coming today. Welcome, welcome, and we really appreciate your participating in the briefing today. I'm Barb Yellowlees, and I'm a member of the CETF Board of Directors and the chair of the Telehealth Committee. So the purpose of today's meeting is to review CETF's vision for telehealth, the impetus for the telehealth fact-finding, and to acknowledge the progress and opportunities. I'm going to start with a little disclaimer. I always say telemedicine. I'm being forced by Sunne to try and use telehealth. So if I switch back and forth, don't get too nervous. It just means I'm the transition period here. I've just been doing this forever, and telemedicine rolls off the tongue, but I mean the same thing. So anyway, a little background. I'm sure most of you on the call know this, but CETF was established in 2005 by the PUC with a mission to close the digital divide in California by accelerating broadband adoption and deployment. We've always included telehealth as a driver towards closing the digital divide. COVID highlighted the need for all Californians to be able to access healthcare services through telehealth, which requires broadband and the devices. It forced a rapid expansion of telehealth across the state and the rest of the country, which makes people like me very happy. Those of us that have been promoting telemedicine for 20 plus years, we're really delighted to see it finally get propelled, become more useful, more accessible. However, COVID also exposed there was a digital access inequity. Those who had broadband and computers, like everybody on this call, had no problem accessing healthcare through telehealth, but many underserved communities could not for pretty obvious reasons. No broadband, no devices. So about a year ago, gosh, it's over a year ago, when COVID first struck the nation, seniors were sick and dying at alarming rates. Every night on the news, I think we were all pretty horrified by the devastating health crisis that we were seeing in the nation's nursing homes. Our board had a meeting and we were talking about, gee, we've been trying to promote this for a really long time. What can we do? We just felt compelled to come up with something to focus on one area using telehealth to do something about the COVID pandemic. The board had a long discussion and came up with the commitment to focus on trying to set up a telehealth model program in nursing homes for the benefit not only of the patients or residents, I guess it's more appropriate to say residents, but also the caregivers, people who work in those nursing homes. So Sunny was directed to set up a model telehealth program, which of course she did. She hired Leticia, brought her on, and the two of them set up this incredible program that is up and running. And knowing Sunny, she's got plans to expand it. So hats off, Leticia, Sunny. I think we are going to benefit from this greatly in California, but we're hoping too that this becomes a national model. So thank you so much for everything you're doing with that. Last October and December, Sunny organized statewide telehealth fact-finding convenings. Probably a fair number of people on this call today were involved in that. And for everyone who participated, again, thanks so much. We gathered a lot of information. The whole point of the convenings was to gather information about what's going on with telehealth, telemedicine in the state of California, and to invite suggestions for how do we expand this? How do we get telehealth going long after COVID and make it part of healthcare services in our state? Today, we're going to share the highlights of the final report and action plan that came out of the two convenings. It's important to acknowledge that a lot of progress has been made, and we do celebrate that. We also want today to discuss opportunities that exist both at the state and the federal level to help address what else needs to be done. During this briefing, we're asking you to think about how you and your constituencies can further advance telehealth. Where are the opportunities to advance it? How can you join with others and support telehealth in California? Lastly, we will be sending a letter to both the California congressional delegation and the California legislature and our governor, requesting their support of the telehealth action plan. We hope you will also sign on to this letter. So again, thank you for your partnership, your participation. Really looking forward to today's suggestions. I really encourage you to comment, to add your thoughts. We're always open to new ideas and suggestions. And with that, I turn it over to our fearless leader, Sonny Mcpeak, our CEO for CETF.
Thank you so much, Barb, and thank you for leading the telehealth work on behalf of the California Emerging Technology Fund since 2006. And before that, doing pioneering work when I was working for the state that informed the California Public Utilities Commission on the need to address telehealth as they were considering mergers in 2005. So they actually relied on a major report and set of recommendations that Barb, Johnston, Yellowlees produced for the cabinet, for the governor's administration in 2005. It is a pleasure to join Barb and our Treasurer CFO, Rich Mata, on the board of directors today, and just welcoming you. Before I go on and make any other comments, I want to turn to Leticia Alejandrez, who has taken the responsibility, as Barb described, immediately coming on board to CETF and becoming the Director of Telehealth and Human Services. And she wants to make some announcements, and then I'll do a sort of just a brief overview of what we're going to see today.
Great.
So, Leticia.
Okay, thank you, Sonny. Thank you again, everyone, for being on the call. We are really appreciative that you've joined us today. Just wanted to let you know a couple of things. One is that if you don't have the agenda, it is in the chat box, so please avail yourself to that. This session is being recorded, so we thought it was important for you to just know that that's happening. So you might want to make sure that you don't have any additional or external noises. And the PowerPoint and presentations that are going to be presented today, they will be brief, but if you would like to have copies of the slides, we will be posting them to our website. Lastly, if you would like to have a good interaction with this Zoom call, I strongly encourage you to change the view of and go to the upper right hand corner, and you will see a little box and it says view, and turn it into speaker view, and it'll be a lot easier for you to enjoy the session. So with that, Sonny, I'll turn it back over to you. Thank you.
Thank you very much.
Sure.
For everyone who is joining us, who participated in October and December, you know what a robust set of presentations we had. Rich data, experiences from every segment of the healthcare, medical care community, if you will. And each of them had a very resonating and reinforcing message about the potential of telehealth. I often say, and also telemedicine. So we are able to do both. And Barb wants me to say only one of them. So we've chosen what we thought was the broader umbrella. But we understand we are talking about how to improve outcomes for patients by having better quality care, support for the caregivers, and then by using technology, increase population health. So that's what we are about in this work for the California Emerging Technology Fund. While we have a mission around technology, we also understand technology is just a tool, and that it has meaning when it's used to help people improve their lives, save time, save money. And that is what we heard from all of the presenters in the fact-finding listening conferences. You have the summary report and have a lot of the specifics that came from all of the experts and the responders that participated. We summarized the overarching challenges in an action framework that was three basic things. Might have seemed obvious when we began, but certainly got confirmed and reinforced through the fact-finding listening conferences. The first is we've got to have robust, high-speed internet infrastructure everywhere. The connections need to be not only among providers, but from providers to people, their residences. The shelter in place orders made that so clear and so graphic. And I think it's very interesting that today, in all the discussions about investment in high-speed internet, which is what we call broadband. Broadband's a generic term for that, including wireline and wireless. There is almost a second refrain that is spoken to say it must be sufficient to support telehealth and distance learning, but everybody understands the importance of having that infrastructure throughout the state. So that's the first big action in the framework. The second is there are amazing experts and pioneers in telehealth in California, a fairly mature set of policy leaders from the community, from the practitioners, and they need to be supported with adequate resources and reimbursement policies that continue going forward post-pandemic. And the third is that in order to optimize the use of telehealth for patient care and population health improvement, we need to institutionalize telehealth as a part of our health and medical care system. We need to understand how to harness the power of technology, the efficiency of direct connections via technology between patients and their providers. And you're going to hear a discussion on each of those as we go through today. Really important at the end is that we have new data that no one else has ever gathered to this point in California or to our knowledge across the nation, which is how do residents anticipate they're going to engage with the healthcare system going forward? What is the mix of telehealth visits versus in-person visits? That's going to be very important to inform the planning for infrastructure and to allow the providers to balance how they program and allocate resources. So with that, I want to tell you this is a very exciting time in California and in the country. There is a lot of discussion going on, and the information and expertise you all contributed to the fact finding is certainly a part of now that expert information, that technical information being relied on by policymakers and regulators. Thank you again for participating. The letter that we all want to invite you to sign that Barb referenced is important to mobilize. We have to continue to say over and over again, here are the three big things to focus on and make sure that they are front and center for policymakers and regulators. So with that, Leticia is going to summarize for you, just so we have it all framed up, what we heard from you, what you have in the summary report, but so that we get it also really internalized into our thinking. I thank you again for your participation last fall and today, and to Leticia Alejandrez now.
Thank you, Sunny. Perfect. That's great. Well, I just can't reinforce enough how excited I am that we're at this point, because we did hear from some outstanding practitioners in the field on telehealth, and the information that they provided that makes up this final report is pretty amazing, and I'm very excited about it. And I'm hoping, as Sunny mentioned, that each of you will take some time to read through it. Rosa, I'm going to ask you to pull up the PowerPoint. Perfect. Thank you. So I'm going to make my comments brief, but what I'd like to do is just give you a quick overview of the fact-finding convenings, really just reinforce. I know Sunny just talked about the vision and purpose, talk a little bit about the gaps and barriers that we heard, and then talk a little bit about the recommendations that really do make up this 3-point action plan. So that's what my assignment is. So let me just reiterate again. I think it's worth reiterating with the vision for telehealth. the importance to optimize the use of telehealth in California, particularly for medically underserved communities. And our goal was really around ultimately improving patient outcomes and overall health status. And this is all in the midst of COVID-19. And although COVID has been a huge challenge with lots of tragedy, I also have to say it is a gift that keeps on giving. It is one of those things that has made us turn to telehealth. So I'm super excited about that and the opportunities that it has presented for us. Next slide, please. So the purpose of the fact-finding listening conference was really threefold. So we were asking ourselves, so what's the status of telehealth in California? Where are the gaps and the barriers? And based on recommendations that will inform policy and funding, what should this action plan consist of? And I will tell you, Sonny and I went through reams and reams of the transcripts from these convenings. And I will tell you, there was such rich information. The challenge was, what we could include and what we couldn't. So I just want you to know that it was a real challenge, but we really felt it was important to distill the information to a point that it was really able to be processed. So that's really what our hope was with this final report. Next slide, please. So, in identifying the gaps, it became very clear in our discussions that there were really kind of two categories. One were the gaps with individuals or consumers, and those with the medical institutions and providers. And so let me just very quickly go through these three. So for individuals, the gaps are really around the insufficient access to broadband and devices. I mean, if you're wanting to have a telehealth appointment and you don't have a smartphone, or if you don't have a tablet, or if you don't have a computer, that creates a huge challenge. And we saw that, we heard that. And then the affordability for adoption. I mean, that was huge. The need for language, culture, creating trust within communities, and the ability capacity in telehealth. Those were all very important issues that were creating gaps for people in accessing telehealth. And then the third is really kind of encompassing all of this, and that's really the lack of consumer information on telehealth. So how do I access telehealth? How will my privacy be protected? What do I need? What kind of an environment do I need to be in, and so on. Next slide, please. Next slide. Great, thanks. So the gaps as they relate to medical institutions and providers, what we heard was that there was lack of support for deployment, training, and technical assistance. Now, that's not to say that there aren't folks that are in these facilities and providers who are champions, because that's what we learned as well, is that if you have a champion at a high level, that it's more likely that you'll be able to implement telehealth. We also learned that the gross underfunding of telehealth was really apparent. And then the third area was really around reimbursements. I mean, that was something that came up time and time again across sectors with regard to, what's going to happen post COVID-19? What's going to happen to these policies? So next slide. So it really boiled down to these three recommendations that really make up the action plan. And I'll get into a little bit of detail of some of the recommendations that fall under each of these. The first is with regard to reimbursement. The second, as Sonny mentioned, is about infrastructure, investing in infrastructure. And the third is institutionalizing telehealth. So those are the three pillars that make up our action plan. Next slide, please. So let me start off with the first, what I'll call the pillar with regard to reimbursement. So what we heard was three recommendations that really talked about, so it's important to sustain telehealth reimbursement at the same level as in-person versus via telehealth. That's what we heard time and time again. We also heard that multiple modalities for the delivery of telehealth services was really important. asynchronous, synchronous, telephonic, all of it, remote patient monitoring, all of that was really important. And the third, which I thought was really interesting, was around public policy. I think this was really more of a, when policymakers make a decision, then the practice has to follow, right? And what we heard was, like in long-term care facilities and skilled nursing facilities, that although providers were able to bill for it, there was nothing on the form that showed them where they could actually get this done. So we went to the governor's office, and hopefully they've corrected that problem. But it's those types of things that were coming up. Next slide, please. So the question becomes, so has there been any progress made here? And I'm happy to report, and I know many of you already know this, that there has been progress made. There have been people who've been listening, people at the state level, people at the federal level. And one thing I wanted to pull out, I don't want to preempt one of our speakers, Trong from CPCA, who will be going a little deeper with regard to reimbursement, but I thought it was important to really pull out this quote from the Department of Healthcare Services, where they say that, DHCS is looking to modify or expand the use of synchronous telehealth, asynchronous telehealth, telephonic audio only, other virtual communication systems, and to add remote patient monitoring to create greater alignment and standardization across delivery systems. And I think that this really, for me, it really struck me, and when I read the document, it really struck me that they were paying attention. I mean, we still have work to do, and there's some flexibilities that they're not going to recommend for continuation. And like I said, Trong from CPCA will address that. But the mere fact that the document, and I'm asking Nadine to put this document in the chat at the end of my session, so you can take a look at it and see what the Department of Healthcare Services is thinking and what their priorities are, and what are their policy recommendations, as well as what's in their trailer bill language. So you can kind of do a quick comparison. So there's been some traction there. There's been a lot of traction and a lot of advancement there. The other is with regard to the Department of Managed Healthcare, and I'll have Nadine put that document in the chat as well. And that's AB 744. It's a bill that was adopted, I think it was like a year ago, and it wasn't supposed to go into effect until I think this year, but they said, let's make this happen sooner, even though it really wasn't designed for COVID. It was the perfect storm. It's so much of this was related to telehealth, and it made sense. And it made sense to implement these telehealth supports earlier rather than later. So I thought that was a great indicator that our policymakers were listening. Next slide, please. So other reimbursement related recommendations, I thought these were really important to raise as well. Again, the challenge is always distilling so you can get kind of the nuance of what we heard from presenters. And one was authorizing, having a recommendation to have Medicare and Medicaid reimburse for devices for low-income populations. Again, the issue of people not having, consumers not having access to these devices in the first place. It's how do you make them available to them? The second was really around, and I think Dr. Yellowlees was one of the people who really drove this home for me, was with regard to advocating for permanent elimination of CMS geographic location restrictions post-COVID-19. Now, I think he raised the point very succinctly that rural, CMS really does focus on rural, underserved, disconnected communities, but it's not only rural communities that need to have access. There are those in metropolitan areas that also lack access. And I believe he cited a study that demonstrated, that how many people were really availing themselves of this and how many were coming, and a huge portion were coming from metropolitan and urban areas. So that was a big key area. And the third was really around continuing or having the ability to continue prescribing controlled substances via telehealth after COVID. Next slide, please. So the second pillar, and this Sonny mentioned, and I think this undergirds all things. So we need to invest in and ensure ubiquitous high-speed internet infrastructure to support telehealth for all patients and providers. This is something that I felt like there was almost like an explosion with COVID-19. Suddenly, we could no longer be blinded by the number of people who are at that digital divide, or what Sonny calls the digital cliff. We could not deny the fact that there were people who just did not have access. And I think that it certainly made the case for all of us that we cannot live in a society where everyone does not have access to digital or internet and broadband and access to digital devices. So what we heard was it is important to invest in broadband access, devices, and adoption. And it's important to invest in telehealth infrastructure, equipment, and training. And undergirding that, we heard that part of this infrastructure and part of this investment in broadband, it must also include expanding provider training and technical assistance, expanding consumer information on telehealth access. How do we build the capacity of consumers to receive telehealth and participate via telehealth and access via telehealth? And again, we see the third point that has to inform this telehealth infrastructure, and that's really the need to understand culture and language and building trust in communities and providing the necessary supports and services for communities who do not have access or have limited access or have barriers to access, such as with interpretation skills when English is not their first language. And then the last area is really around HIPAA, which is when it was enacted in 1996. It's time to revisit HIPAA. It's long overdue. It needs to keep up with technology. Next slide, please. So the good news, the progress. And again, I have a document that I'll share with you. This is President Biden's American Jobs Plan with regard to infrastructure. And the proposal, it contains $100 billion investment for high-speed broadband infrastructure. And it contains a lot of different things. It also reduces the cost of broadband internet service and promotes more widespread adoption. It also includes, it includes a lot of different things. It also includes things that we're interested in, like long-term care. What does it mean for that? So it does present many opportunities. And I think given that those dollars are going to be trickling into, maybe showering in to California, hopefully, this final recommendation is super important. But let me just say this very quickly, and Sonny, you might want to say something about this after my presentation, but AB 34, it's pending legislation about broadband for all. It issues $10 billion in bonds if it indeed passes the legislature. There's the FCC that has COVID-19 telehealth program for $250 million. This is the second round. Those dollars go quickly. And then recently there's the HR 1319 American Rescue Plan. It has $190 million in it, and a lot of it goes for Indian health as well. But in any case, I just wanted to give you a flavor of what some of the progress that's been made, and really something for us to celebrate. I mean, there is traction. So let me just end with the third pillar, and I think this brings it all together. So Rosa, can you advance the next slide? Nope, one more back. There you go. So this is really around institutionalizing telehealth. What we know for sure is that unless and until a body, an agency is responsible for accountability, it resides nowhere. So we need to make sure that there is an entity within state government as well as externally to really optimize telehealth and to have the necessary goals and performance metrics to make this happen, that really creates this comprehensive telehealth program in California. And California tends to be the leader. We don't follow. And I think that there's lots of legislation that that's being considered. I think I saw like, I don't know, 30 some odd bills. None really address this specifically. Some said, let's have a report in 3 years. And again, coming from CETF and learning from Sonny, yesterday is too late. So this is something that needs to happen sooner rather than later. And we're really hopeful, and we plan to get the attention of policymakers and leaders like yourselves to really mobilize and organize to make this happen, because we can't afford for it not to happen. So with that, I'm going to stop. I'm going to say thank you again for each of you for being a part of this and for making this happen. And let's figure out how we can move forward. So with that, I will turn it back over to Sonny. And I probably took up a little more time than I should have, but let me pass it along to you, Sonny.
Excellent. Thank you so much, Leticia. I think we're ready to move to our session with Trong and take advantage of the expertise from the California Primary Care Association. In addition to the bills, I will just say that Leticia highlighted, there is AB 32 that Cecilia Aguirre-Curry has that looks at reimbursement for the Medi-Cal programs, including those that are publicly sponsored managed healthcare plans. And there's also a lot of expectation that bills to extend authorization into the California Advanced Services Fund that will net about $1 billion for infrastructure will be successful. So with that, let's just go to our next session to look at legislation to reimburse telehealth services. So Trong, I think you are up, and we appreciate the California Primary Care Association being a co-sponsor of the fact-finding session and of this briefing session.
Yeah, thank you, and good afternoon, everyone. I hope everyone's hear me okay. Just give me a thumbs up to let me know. Great. So again, my name is Trong Lei. I am the Assistant Director of Policy at the California Primary Care Associations. We are the statewide association representing almost all of the community health center and clinics here in California. The health centers often serve Medi-Cal patient populations, uninsured patients, or those that are underserved, medically underserved, or in area where there's often lack of access to care and services. So let me, can I go to the next slide, please? So let me just start out by quickly go over the comparison between telehealth policy before COVID-19, during COVID-19, and what's in the DXCS telehealth proposal. And I would just start by saying that, right, telehealth is a safe and effective and proven model of care that has the support of both patients and providers. And since the beginning of COVID-19, there has been numerous studies on the effectiveness, on patient satisfactions, on the benefit of telehealth and telephone. As you can see on the slide, prior to COVID-19, live video and store and forward. So those are the terms for synchronous and asynchronous care, telehealth care. Those are reimbursed at parity, and that means that they are reimbursed at the same level as in-person visit. That is the same currently during COVID-19. However, in the DXCS proposal, they propose that only live video reimbursed at parity, and store and forward along with audio only and remote patient monitoring will not be reimbursed at parity compared to in-person visit. Calling specifically to the third bullet there on in the first column, FQXCs and RXCs prior to pre-COVID-19, we are limited in terms of how FQXCs can provide telehealth or telephone. For specifically, we were not allowed to provide telephone and bill for those services prior to COVID-19. Now that currently was changed because of COVID-19, because of all of the shelter-in-place orders. FQXCs are allowed to provide telephone visit, and all of the prior restrictions that apply to telehealth were removed. Some of those restrictions include whether a patient is an established patient of a health centers, whether the service have to be within the four wall of a clinic site, whether the patient has to have a face-to-face with a provider in order to receive the telehealth. In the DXCS proposal, DXCS kind of took a step back. Well, let me say that DXCS proposed to allow FQXCs to continue providing telehealth, video telehealth services to their patients, regardless of where the patient is. So that means that the patient can be at home and receive the video telehealth services. The DXCS took a step back, in our opinion, compared to current policy, where it discontinued the telephone flexibility for FQXCs and RXCs. And that means that in a post-COVID-19 environment, FQXCs and RXCs will not be able to continue to provide and bill for telephone visit, as well as asynchronous telehealth or remote patient monitoring. And then the part of I guess the reason why I want to call it out specifically is because, as noted by Leticia and Sunne at the beginning of the call, we have a digital divide issues in California, especially when you look at the patient population that's served by community health centers. Those patients are often the one that live in area where there's not available broadband internet access. Those patients are often the one who do not have the means to afford broadband internet, and those are the patients who often do not have the devices to leverage the video telehealth. But in a sort of counterintuitive proposal, DXCS exclude those patients from continuing to receive telephone visit. And that's why we have a very deep concern with DXCS proposal. We do commend them in a way that they will, expand telehealth, video telehealth for FQXCs and RXCs significantly in a post-COVID-19 pandemic environment. But when you look at telephone, DXCS did not make the equivalent advancement that it did for video telehealth. Can I go to the next slide, please? So just want to showcase some of the data that we collected at the very beginning of the pandemic. We conducted a survey through our community-based organization partners to survey or to poll the number of patients who often are special patient populations, or those who are minorities patients, and ask them about their access to internet and what sort of challenges that they have when they access internet, so that we can better serve them or better kind of channel our capacity to provide the needed care to our patients. As you can see on the left side, when we poll those special population patients, the majority of them say that they do not have, or they experience challenges with accessing internet by type. And they are ranging from 52% to 61%, but the majority, right? I mean, but of all of those categories, the majority of patients have those challenges. When you look at the right side, it's broken down by race and ethnicity. And you can see this, a similar pattern here, that the majority of those respond to our survey they express that they have challenges accessing internet. And why is it important, right? Because when we look at telehealth and the proposal that DXCS put out is make a very big step forward when it allow FQXCs and all of the providers to continue to provide telehealth and be reimbursed at par with in-person visit. But when you look at audio only, especially when you look at the patient that we serve, that in real need of having that access to telephone visit, this is very confusing and in a way that is appalling to us, because our patients who need access to telephone visit the most get excluded, right? And because we do have the digital divide, and because we know that we are working on it, we don't have any other mean between now and when we have a system in place to provide needed service to the patients. And then can I go to the next slide, please? So want to show you this graphic in a way, because when we look at the data, and when we look at the digital divide issues that we are having, the question then become, what would be an equitable solutions, right? Because for those who need telephone visit, they should be able to maintain access to that modality because they don't live in the environment where broadband access is readily available to them. They don't have the ability to access video telehealth services. And of course, when you look at those patients with transportation challenges, regardless of where they are, even if they live in a rural area where they have to drive hour from their home to the doctor office, or if they live in an urban area where they have to take multiple buses from where they live to where the doctor office is. That pose an equity issues in our mind. And that's why we, earlier this year, late last year, we worked with a group of different provider associations and with Assembly member Adia Curry to introduce Assembly Bill 32. And the crux of that bill is to ensure that telehealth, video telehealth, async telehealth, telephone visit, all of those modalities are available to all type of medical providers in the state, and that they will get paid the same compared to in-person visit if the services are the same. And that's what we continue to push. That's what we continue to dialogue with both the legislature and the administration to make sure that we can remove the barriers, the system barrier right now. And until we have a good infrastructure in place so that everyone have access to broadband internet, we will continue to maintain that telephone visit for all medical and for all of those who need them. Let me just stop there and see if folks have any questions.
I don't see any questions in the queue. So thanks, Trong.
Yep, thank you.
It was excellent. Thank you very much. So Trong, I have a question. Because of your sponsorship of AB 32, the time frame for collecting the data, rolling it up, and getting to an assessment of how to, what we would say, optimize the use of technology, the use of telehealth to improve patient outcomes and enhance overall population health. That seems to us to be longer than we would hope to wait, because you rightly pointed out the sense of urgency that we have. Leticia talked about it. I love always the graphics in terms of equality and equity and justice. And so we're trying to take down the barriers. We're trying to take down the walls. How can you just address that time frame? And is there any room to compress it and do an amendment to AB 32?
Yeah, that's a very good question, Sunny. And I would say that, right, I think it's like achieving world peace in a way that, you know, we want an ideal system where everything's works for everyone. But I mean, understand that there will be challenges, understand that we have limited resources to ensure that everyone will have super fast internet access. Everyone will have a good device to use video telehealth. I think earlier when Leticia shared, you know, some of the progress that make at both the federal level and at the state level, funding are coming down from the Fed to ensure that, you know, state to ensure that plan providers receiving some of those and divert some of those resources to patients. I think it takes time for us to ramp up that effort to ensure that both from the provider, from the digital device standpoint, that we can improve the broadband infrastructure. We can provide bit by bit funding or support to our patients, to our provider to get smart devices so that they have the means to provide video telehealth. It's give us some time to educate the patients on how to use those devices and how to even use the app to access a video telehealth. All of those take time. And would I say, you know, 2 years is enough, 3 years is enough? It's hard for me to say. But I think that as of right now, everyone needs some sort of commitment from state and federal government that telehealth and telephone will stay, even for a short period of time, so that they can continue those investments, right? Because if tomorrow our federal or state policymaker say that there will be no more telehealth after the pandemic over, which what we were operating last year, nobody gonna want to invest in telehealth. Nobody gonna buy the extra iPad or the extra smart devices so that they can continue to provide telehealth, right? So we need that sort of commitment, regardless of how long it is, so that they can continue to invest in building up that infrastructure from the ground up, from the patients, from the provider, and from across the state.
So I have one follow-on question, and then we do need to move on. Am I understanding, Trong, that from the Primary Care Association, AB 32 is your primary vehicle to take the next step in telehealth in California? That's true, right?
Yes, that's true. That is our primary vehicle. I would say too that because the XCS put their proposal in the budget, so we somehow have to respond to that process as well.
Correct. So for everybody, for you and everybody on this call, one of the questions to reflect on is, could we look to in the budget control language, as Trong just said, because the administration has that proposal, and also in AB 32 for more progress than 3 years out, reporting back. That is in part what you're going to hear when June talks about institutionalization. So I want to pose that, and thank you for addressing the question.
Thank you so much.
Thank you, Trong. I really appreciate your comments and also your point. We really do have to strike while the iron's hot. I think we need to take advantage of that opportunity. So thank you with that. I'm going to move us along. And next we're going to go to Louis Fox, who is President and CEO of CENIC. So Louis, take it away. I think you're on mute.
I was asked, thank you, Leticia. I was asked a couple of questions. First was what surprised me about the findings. And I was actually both surprised and pleased that across a diverse set of policy people and practitioners. There was unanimity about one, the value of telehealth, two, how the pandemic had really dramatically changed the pace of adoption, and how it had also caused many providers to reimagine the way they deliver healthcare. And lastly, the absolute need to get broadband to every home and every medical facility and setting in California was sort of a necessary condition for systemic adoption of telehealth by both providers and patients. Next slide, please. Yesterday, the California Senate issued this proposal they're calling Build Back Boldly. And I read through it with a mixed response. First and foremost, I'll note that in the higher order imperatives, they did indeed say expand access and affordability of healthcare. So that is consistent with what we've all been talking about. The proposal is to build a post-pandemic economy that extends prosperity for Californians and invests resources to address the state's most pressing needs in innovative and equitable ways. And I do want to focus on the innovative and equitable. Next slide, please. In the section on state systems improvements, in some ways, almost as an aside, there is a notion that we should invest in broadband infrastructure to achieve universal internet access. Clearly, it's not linked back to any of the themes of whether it's equitable access to healthcare or education. And then a note that the federal stimulus funds are available for this purpose. I think I could imagine broadband actually being a top level theme of this multi-year plan. Next slide, please. I did want to note there are 3 major stimulus acts that have been enacted and the funds have been appropriated that have broadband components in them. There is it's 7.17 or something like that billion to be added to the E-rate program that will provide some reimbursements for home connectivity purchases, both for connectivity and for devices. And there's some opportunities to rethink some of the more onerous rules that guide the federal E-rate program. There's 1.2 billion from the Department of Education that can be used for connectivity purposes. There is $3 billion emergency broadband benefit program, which provides eligible participants with up to $50 a month subsidy for broadband, as well as $100 for a device. That program is all driven by providers. So the provider has to offer that subsidy. I'm happy to say, though, many providers are signing up for that. There is $20 billion in the Rural Digital Opportunity Fund. It includes a second reverse auction, but it does call out a couple of special programs, $1 billion for tribal broadband and $285 million for infrastructure in minority communities. Those amounts, while large, are sort of...
Okay, I couldn't find one of my shirts, but can I buy one right now? Okay, thank you.
That wasn't me. Anyway.
Bring it in.
Sorry about that, Louis, go ahead.
Okay, so they're good amounts, but they are not commensurate with the need. Lastly, there's $350 billion that will go to states and localities that can, 10 billion of which is more specifically focused on broadband infrastructure. $340 billion is a variety of infrastructures. This money resides with the Treasury Department. Well, we can talk more about how that's shaping up if people are interested. Next slide. It's also important to be cognizant of both the President's $2 trillion infrastructure plan that has a significant section in it about revitalizing America's digital infrastructure. And there is a complementary bill in the Senate proposed by Senator Klobuchar and House Majority Whip Clyburn that has $94 billion to build high-speed broadband infrastructure in unserved and underserved communities. Next slide, please. So what's the action plan for us, particularly vis-a-vis these federal programs? I believe we have a need to do more advocacy and education, a campaign, if you will, so that the role of broadband for telehealth and access to healthcare is at least as well understood as the homework gap. Almost every day during the pandemic, somewhere in some major newspaper, you saw someone editorializing about the homework gap and the inability for students to have continuity in their education. I believe we need to have the same focus on telehealth. And the programs that fund telehealth actually have not been called out in the federal programs. There is a universal services fund that funds rural telehealth, but it's a modest amount of money in comparison to the sums that I've been talking about. And I think we need to focus on two facets of broadband. Broadband to every home or every residence, and broadband to every healthcare institution and setting. Next slide, please. And I want to make sure that we, that is CENIC, as a public benefit corporation, are committed to whatever effort comes out of this process. We have a very capacious broadband backbone in California, and we reach into every county in California. Now, right now, much of that reach is problematic because it's directly to county offices of education, which have prohibitions on sharing those nodes. But imagine, if you would, that we built out other nodes in every county that healthcare institutions could connect to. As I said, we're committed to working with you and to doing whatever we can to address what I now think of as the healthcare divide.
Great, that's great. Thank you, Louis. That is spectacular. Good to hear that you're on board. You're willing to see this through. So we appreciate that. Let me check to see if there are any questions in the chat. Nadine and Rosa, I'm not seeing any unless I'm missing them.
There was one question posed, but we were thinking maybe we would ask Miss June Simmons.
Okay.
By Karina Berrigan, but I think you wanted to save that for later on.
Correct. Yep. Thank you. All right. So with that, let's move on to June Simmons, who is the president and CEO of Partners in Care Foundation. So thanks and welcome, June. Thanks for being here.
Well, thank you. And I so appreciate you having a community-based organization at the table. We're proud to partner with you. We are an organization that provides strong safety net around integrating social care and healthcare. And social determinants of health have been, we've heard them referenced throughout. So that was one of the things that I found instructive in the listening sessions is there's an underlying implicit agreement that these factors are very important. And yet, as we describe health, primarily solutions are around healthcare interventions, and we believe the two should be integrated because the social determinants are so powerful, and the digital divide is one of them. This is one of the areas where trusted alternative workforce can be a bridge to help people make use of the resources that we're all striving now to universalize and really make fully available. So I was very delighted to discover, as you say, what surprised you in the listening session, the real commitment that we've discovered really for all population, but certainly for those at the lower end of the income scale, those who are in the other groups, the people of color, all the different specific populations that we see the inequity results, that this is part of the solution, but it should include the implied but not made specific social solution. So I was glad to be invited because typically it's healthcare personnel, and in this case, tech personnel, and wonderfully committed strategic folk. I'm excited to be added to the table. So in terms of the institutionalization of telehealth with accountability to improve patient outcomes and overall population health, we share that complete commitment that we've been hearing from each of the really wonderful presenters here this afternoon. And of course, we see also a lot of progress, dramatic progress. I think we all discovered this amazing shift in virtually overnight with the lockdown, which was a fabulous opportunity. However dire the inspiration, disruption that leads to positive change. At least we'll get, I always say, if you're going to have the pain of the pandemic, let's have the gain of the things we learn that we must have and put in place the changes that are essential. So, so we could see how the waivers removed significant hurdles in this emergency circumstance, and it was fantastic. And for us, we typically go to the home. We look at what happens at home that drives health outcomes and population health results. We really weren't supposed to be going to the home during this time. We're just beginning to look at getting back. And so even for us, these kinds of virtual interventions and service delivery systems, critical, very critical. And happily, we are not paid in the same way as health, although need to be with them. At least our funding sustained, because our role is to keep people out of nursing homes, out of hospitals, out of ERs, keep them living safely in the community. And under COVID, that was a highly respected functionality, maybe not always so cherished, but cherished at the moment. So, so we benefited from those temporary waivers that we could get results for people. And certainly we could see in the right circumstances, sometimes calcified systems, reluctant and resistant and financially driven not to change, could turn on a dime just overnight. We did the same thing. We took our 200 staff, put them working from home overnight, very effective, sustained. So, but we share the same kinds of concerns that we were just hearing about, that some of the waivers, while becoming permanent, will not be complete. And we do think, you know, that the telephone only is crucial. We're not in 1 minute. As fast as we respond to the pandemic, we won't get devices and broadband in everybody's hands and have everybody accept them and everybody know how to use them. And so I think that it is very important to have the new regulations allow as much flexibility, and I might add, hopefully support the inclusion of solutions that address social determinants of health. But certainly we're very concerned that the FQHCs and the skilled nursing and assisted living facilities, the managed healthcare plans, public sponsored health plans, and medical centers and veterans affairs, all these audiences really, really important to retain some of the advances that they make. So we know it can be done, but we know it's going to take public will and funding. And we've seen a lot of progress in the recent funding. We were just hearing about this spectacular waterfall of funding that may roll out, and now we got to get it right. Now we got to use that. So getting that infusion, I think, is fantastic. Because even in California, the Center of Innovation, we haven't yet optimized fully in regular practice the use of telehealth to close gaps, especially for medically underserved communities in the economically segregated neighborhoods, where these are home to most digitally disadvantaged residents. They are also home to highest cost. Cost in terms of suffering because we fail to address modifiable risk factors, and therefore subject to highest cost of healthcare. You know how America waits a long time until you're sometime for some of these populations. People, when they get in trouble, we spend endless amounts of money on them, but on the upfront side, sometimes not so. And telehealth is going to be critical to evening the out. We could see the results from the listening sessions of the drop-in no-shows for mental health and for office visits, the ready access to timely service, right care, right place, right time. So that's crucial. But what we haven't seen yet from the state and in most of this legislation, I think, is whose job is it?
Yeah.
I think Leticia was saying it, you know, we've all agreed about the pathway, but not the method. And so I think it is crucial that this is someone's job, and that it's a designated someone with the proper kind of backing and resources and accountability. So definitely the state should have designated leadership, but of course from the community side, from the rest of us, a nonprofit leadership site that can make this a true public-private partnership, I think is really, really critical. The state can do things no one else can do, but on the other hand, the private sector also can do things the state can't do. There is a greater flexibility, there's a greater closeness, of feet in the street, if you will. And so I think this is vital to have this designation of whose job it is and putting that in place with an effective telehealth action plan. That's really going to be built on the expertise we already have within Health and Human Services Agency and healthcare services and other key stakeholders we've been hearing from today. There's some tremendous leadership that's been at this for what, a couple decades, committed work, striving, working against resistant forces of change. Okay, we're in a moment of an inflection. We're in a moment of transformation. We have to seize it. We have to get it right, because like an earthquake where you have liquefaction, you have a moment when things are fluid, then they seal up again. So we know this will seal back up again. So regulatory relief, infusion of resources, the proper vision, the proper measurement and methods are all going to be critical to moving this forward. And so I think especially looking at the neighborhoods that have the highest risk, the greatest array of modifiable risk factors that will in fact change population health outcomes, the least access, the most mistrust, the most anxiety, the least comfort. We really will need to do outreach, engagement, working through a change process at the consumer level in partnership with these public-private leadership organizations that we need to have. So I'm hopeful that community-based organizations, ours fine, but you know, there's a big array of community-based organizations that are in communities that can be the outreach to engage people so that we could get this so it really becomes a new norm. This becomes the way we live just the way we live, that we can spread that. So everyone has the equal ability to be able to pick up the phone, pick up their device, and connect right away and get what they need. So I appreciate the opportunity to comment here and to be part of this tremendous work you're leading.
Great. Thank you, June. Thank you. It is really great to have you as a partner as well, and the work that you do in communities and the bird's eye view you have there. So I think you bring a lot to the table. So thank you for making the time to share it with us. I don't see any questions in the chat. Rosa, Nadine, am I missing something? Okay, I think we're good. So I'm going to go ahead and pass it back over to Sonny. So Sonny, you can bring us home with Dr. Hernan Galperin.
Thank you, Leticia. It is really exciting to us that we are able to share with you today a preview of what is going to be officially released on Monday from the University of Southern California as our partner in doing the independent research for the 2021 statewide survey on broadband adoption. CETF has sponsored this statewide survey since 2008. We've had 3 previous independent research managers, research organizations, and we're delighted that the University of Southern California and the Annenberg School for Communications has taken on the current position as being our partner. And Dr. Hernan Galperin is the lead researcher. USC has really stepped up and has engagement across several schools. Several of the researchers are joining forces, from the School of Social Work to education to gerontology to even in public policy and economics. This is huge. And the purpose of our survey is to see, well, where is California in getting to what we call adoption, which is how many households are online at home. In light of the pandemic, a lot more questions are now were asked in this survey about what do you expect to be your commute patterns, your trip patterns, you're going to the doctor in person versus, if you will, online with telehealth. And so USC has given us all permission for Dr. Galperin to actually share this with us. It's really a service, if you will, to you. You might just consider this a community that has embargoed this information at least till Monday, but we wanted you to have it since it is very timely. And I just have to say, Hernan and researcher Tylee and his colleague, Dr. Francois Barb, immediately stepped up in November and said, yes, we will get this done, and did it at lightning speed. And we now have the benefit of data that no one else in the nation has to inform public policy in California and also at the federal level. So great to work with Hernan Galperin, who also has served on the board of expert advisors for the California Emerging Technology Fund for several years. Hernan, take it away.
Thank you and good morning. Thank you, Sonny, for the very kind introduction. My name is Hernan Galperin. I am an associate professor at the USC Annenberg School for Communication. And as Sonny mentioned, I'm the lead researcher from USC, but this is really a team effort from across campus, various schools, various other colleagues involved. What I would like to do is to give you, first of all, a summary of the results that address the basic question of broadband adoption. And this is what we released a week ago. And of course, this is relevant because I'm sure you've been discussing this the entire afternoon, but telehealth is as good as broadband connections that are on the ground and devices. I think telehealth is a great example of not just the need for any kind of broadband, but really for reliable, affordable, robust broadband connections and good devices that would allow a good experience with telehealth. And that's what we are trying to assess in this survey, is the extent to which households have the ability to have this broadband connections, have these devices, which is the basic infrastructure that telehealth relies on. So let me go ahead and give you the snapshot of those results that we released last week. And then, as Sonny said, I'm going to give you a very short preview, maybe a teaser you could call it, of the results that are going to be released on Monday. But I will show you some of the results, and I think will be interesting for your group, particularly because they relate to our questions on telehealth. I believe I'm able to share my screen. Yes. So just a quick, very quick summary of what the survey, how we did the survey. We interview Californian adults, 1,650 households or cases. This is a telephone survey. We did in 4 languages, majority Spanish, English and Spanish, some Mandarin and Vietnamese. And we adjusted our results to reflect California population based on census numbers. We closed fieldwork March 22nd. So yeah, there's no typo there, March 22nd. So it's been 3 weeks only, and we really want to make sure that these results are fresh. And again, this was just finished, the fieldwork about 3 weeks ago. So the top line, the headline result for the survey is that California continues to have more broadband adoption. This is great news. For the first time, crossed the 90% barrier in overall adoption. So maybe I should take a step back here. We talk about overall adoption, and we include both the connections through laptop, desktops, tablets, as well as smartphone. Now, we also differentiate those who are only smartphone only. We call those underconnected. And as we just discussed, they're underconnected because they don't have the same capabilities, for example, for telehealth. So the 2 really good news from our results. First is that for the first time, again, overall adoption crossed 90% barrier, but also, and perhaps even more relevant, is that we're closing the gap of the smartphone only. Smartphone only went from about 10% to about 6%, so almost a drop of 50% in the number of people who are only smartphone connected. So that's also great news for in our survey. Now, of course, these are not equally distributed, and I'll show you some of the groups that still fall behind others in adoption of broadband. One of the interesting results has to do with connectivity and adoption by race or ethnicity, and in particular, we identified that Latinos or Hispanics, and particularly those that the Spanish speaking, are still behind other groups. And you can see here that overall about 1 in 4 Hispanics still unconnected or underconnected, and that's even larger for Hispanics who are primarily Spanish speaking. Income is also one of the key determinants, as you would expect. Here, what I'm showing you is a division between low income, who is basically 200% or below federal poverty line. Those are low income in our sample. And again, about 1 in 4 are unconnected or underconnected. And obviously, this is much higher than those who are not low income. So income is still very relevant to explain connectivity levels. Age group, this is a very interesting and very relevant, I believe, to telehealth. older adults, in particular 65 and older, continue to be behind other groups. So you see about a quarter still unconnected and some underconnected. But when we look at the overall trends, this is actually the group that has made the most gains in the last year. So here you can see, and this is the green line for 65 and older, and you see this is the group where between 2019, the last survey, and this year's survey, 2021, this is the group that has made the most progress in connectivity. So this is really great, great news, and reflects how the pandemic has in some way created an incentive for this group who was most at risk, who had to quarantine for longer to jump on board with broadband. And this is reflected in our numbers where again, this group is where we see the most gains. They're still behind, but they're seeing the most gains for folks who are 65 and older. And then region. We see here differences in broadband adoption by region, and there's various things driving these differences. Poverty, definitely one of them, and we see Central Valley and Los Angeles clearly behind, and that's again having to do with poverty and low income, but also in the Central Valley, fact is also that there are deficits in infrastructure deployment. So we see that in more rural areas or non-metro areas, we see still a gap in adoption that's driven both by poverty, but also by some of the infrastructure deficits that I believe were also discussed in previous interventions. Now, of course, one of the key questions for our survey is why people still don't have broadband, we ask this in two ways. First, we say, well, tell me all the reasons that are relevant for your family not to have broadband at home. And respondents mention a lot of reasons. It's too expensive, it's at the top, but they also mention privacy concerns, security concerns, what we call digital literacy concerns, not being able to work with a computer, so various other reasons. So there are multiple reasons that are relevant for households that don't have broadband. But then we ask, okay, of all the reasons that we mentioned, which one is the main one? And this is where we see that affordability is still the top reason. And we see that in these numbers where almost 40% say, okay, I have a lot of reasons, but this really affordability is the main reason. And again, we've highlighted this when we talk about low-income folks being less connected. So there's clearly much here to be done in terms of lowering affordability barrier for getting people or more people connected to broadband in California. Okay, pivoting to telehealth. So what questions we had in the survey for telehealth? We essentially ask two questions. First question is, during the pandemic, did you use any telehealth service? Not exactly phrased that way. We actually ask, did you engage in any visit, remote visit, virtual visit with your doctor or nurse through the phone, through the computer, through a laptop, etc. So we both ask utilization and also device, whether this was just a voice call or did it also involve voice and video. So was it a smartphone, was it a computer that allowed not just voice, but also voice and video. And we also ask about what are the expectations for future telehealth use. We say, well, after the pandemic is over, do you expect to continue to use this type of virtual or remote visit with your doctor or health professional? So these are the two questions that I think will be most relevant for telehealth. And again, let me give you just a preview of the results that will be released on Monday. About half of California residents have used telehealth since the pandemic. So about half of people said, yes, I've had a virtual or remote consultation with my doctor or nurse. Of those that said yes, of the half that said yes, about 60% say they expect to continue to use or to engage in telehealth post-pandemic. And of course, there's many differences. There's difference by age, by income, and race, ethnicity. I'll show you some of these. And what I think it's important in the way we interpret these results is that making sure that telehealth reaches those that are most in need and avoid what we would call in sociology, for example, is well known as the Matthew effect. The Matthew effect is simply a fancy way of saying the rich tend to get richer, and those who are ahead tend to get even more ahead. It's the idea of compounded advantage. So the idea is that telehealth is great, but if only those who already have better access to health are using telehealth, maybe that's not the ultimate goal of telehealth, is really to expand availability. So that's one of the ways in which we are trying to interpret our results, making sure that it's reaching everybody, but in particular those that are most in need of this type of virtual health and to broaden access to health services. So let me go through some of the results that we're going to present next Monday. Utilization by age group, we find that the older the age group, the more utilization. Now, I have to be careful here. Older folks tend to have more health needs, of course, but still, the result is very interesting. 2/3 of 65 and older have engaged in telehealth in the last year during COVID. That's a very impressive number. So 2/3 of folks 65 and older have used in some way, either by phone, smartphone, computer, telehealth. Disability, another group which tends to have high healthcare needs, and we also see some interesting results where those who say they have some disability have used, again, 2/3, 70% of them say they've used telehealth in the past year, significantly more than those who do not report any disability. So again, a great, interesting finding for those who tend to have higher healthcare needs. Now, income, and perhaps this is where the findings are more raise some concerns, is we see that those who are low income, and again, we know they tend to have less health options, they report less telehealth utilization. So those who have higher income report more telehealth utilization. They are better connected, so that also explains part of this, but we see here that there's a significant difference in that those who are more affluent are also reporting more telehealth use. And finally, I know that telehealth is often discussed as a way to broaden healthcare access to those who live in rural or non-metro areas. So we divide the results by metro and non-metro. And here, really, we don't see any difference. The numbers, so 46 and 48, those are not statistical significant difference. They are within the margin of error. So basically, we can say there are no major differences. Now, this is an interesting result, though, of course, you are the experts on telehealth, but perhaps we should see more utilization in non-metro areas, or perhaps you would hope more utilization in non-metro areas where access to healthcare facilities perhaps is more difficult. So again, this is something that I would be interested in your comments and questions about. But the findings say that whether you live in a metro or non-metro area, telehealth care utilization is really the same for these different groups. I'm going to stop here. These are the, again, top line results for the survey. More will be released on Monday. And again, thank you for the invitation. Any questions, feel free to, of course, send me an email and I'll stay over, I believe, a few minutes to answer questions. Thank you.
Yes, Sunny, we have a question, Dr. Galperin. Do you know how many of the seniors aged 65 and over that are not connected and or underconnected are from long-term care facilities?
That's a great question. We don't. We did not ask about whether they were in long-term care facilities or whether, we know household composition, but we can't be sure if they are living or in long-term facilities or not. So
Great, thank you.
And if I might add, with the random digit dialing methodology, which is actually the most extensive and expensive to get to the most people in California, that does tend to limit being able to get to residents in or patients in a healthcare medical care facility, because they're not likely to be actually at a phone. So we need to understand that. What the flip side is, it is the way we get to all residents, because we're doing an outreach that gets to anyone who has a cell phone or a landline, as opposed to some list or some subset. But the discussion about skilled nursing facilities, Leticia, should lead you to say, share what Barb and you envision for the program, the pilot with skilled nursing facilities, and how we're trying to learn about those patients.
Right. So thanks for that, Sunny. Two things. One is that we are working with 4 skilled nursing facilities and 1 assisted living facility. And what we are wanting to demonstrate is the efficacy of telehealth. And so as we do that, and in this world, in this environment of COVID-19, you know, are we able to, for example, reduce the spread? And not only within the facility, but beyond the facility. You know, because many of the staff are going back into their own communities, are they being super spreaders? For those that are in a facility, are they able to be diagnosed sooner rather than later? For residents, are we reducing trauma, transfer trauma, because they don't have to go out and to the hospital or to the emergency room to see their doctor, that they're able to have a consult, you know, in the facility. So we're hoping to learn from this pilot multiple things, and that's just a few that I can think of the top of my head at 4:45. But we're really hoping that this pilot will give us that information, and we are working with some great partners. And I'm going to ask Glenn, Dr. Glenn Young, who is serving as our Chief Medical Officer, if he wanted to chime in here very quickly to share some of his thoughts about what we're learning in these skilled nursing facilities and the assisted living facility. Dr. Trong?
Yes, thank you, Leticia.
Sure.
Yeah, so I mean, we're really trying to, you know, COVID hopefully is not going to be a major outcome that we have to study again, but certainly we'll be ready for that, right? Especially now that people are talking about the 4th wave. But there are a lot of concerns with access to providers that are not unique to rural areas. There are issues. One of the hardest pain points that was addressed earlier is just for the facilities is actually a lot of logistical work that is not, there is no reimbursement for telehealth. and this is not sort of healthcare professionals. These are people who run the facilities where their nursing staff are busy. They have a certain ratio that they need to maintain. So we're talking about caregivers, right? There's a huge infrastructure for caregivers. So in the nursing homes, there are professional caregivers. There's a huge shortage of CNAs, not just LVNs and RNs, but actually CNAs working in the facilities. This is sort of almost unheard of. I was working in a facility 2 weekends ago, and one of the facilities could not do any admission because they could not meet their CNA minimum required ratio because people were calling out sick and they're having a hard time hiring new staff. So sort of the reimbursement support to provide telehealth professional services, and also our seniors who live in these facilities, they also need to connect with their family members, right? I mean, they've not had visitors for more than a year, and now we're starting to open up, but obviously, assuming that things will go well, we will continue to open up. So a lot of factors, and Leticia, thank you for holding this session, and thank you all for being part of this.
Thank you. Sonny, we also have another question, and from Barb Yellowlees. Did you differentiate? I think this is for Dr. Galperin, and it's about differentiating by health insurance.
And we did not. We did not. I wish we had more room for more telehealth questions, perhaps in the next iteration of the survey. But we did not. We did not ask for insurance status.
Thank you.
Well, let me comment. Yes, there's also some very practical limitations in terms of how many questions that can be posed and how long someone will stay in the interview. I think USC really struck a great balance, and it is an amazing number of questions that actually did get asked. However, what we also did and are going to continue to explore with USC is how to get at the kind of additional information that is needed. So we asked folks if they are willing to be a part of a follow-on panel to be able to, since they were all selected randomly, they become a scientifically selected sampling of the population in California. We can go back with information. We are continuing to brainstorm across all of the schools and all the researchers about very innovative ways to get at the information that we're seeking. So this is great, and we would like to be able to do that, Barb. And what I would ask of you and others is both how you would like to, what information specifically, and the reason for asking it, so that we can have that vetted with the research panel at USC. So we invite all the rest of you to pose similar questions, but do explain what you want as the information. You don't have to frame the question, just what information do you want? That's why we rely on Hernan and his colleagues to actually frame it, and the actual surveyors. But then we also do need to know the importance of it as you view it for public policy.
Great. And Sonny, we have one last question, and it's, do we have data that specifically applies to low-income seniors living in subsidized housing? I think I know the answer to this, but here's the question.
Yeah. Okay. So, Dr. Galperin, do you want to take it, and then I can add on to as well what we're doing?
Sonny put it very well. We have. It's very costly and resource intensive to do telephone surveys, and we are exploring complementary methods, including online panel, which would allow us to broaden the number of questions and perhaps even do specific surveys for telehealth, for telework, for other issues that are interest in our portfolio. I realize that I left you wanting with more answers because our limited number of telehealth questions. So the answer is no. We don't have I believe the answer. The question was about excuse me, health.
Low-income housing.
Public housing, yes. Sorry, we did not ask public housing. So again, these are all things that, as Sonny said, we are exploring in a complementary online panel, which would allow us to explore more of these issues. And I second what Sonny said. We need to know what the good questions are from you, who are the experts in the field. You're working every day with telehealth. So we would very much welcome what are the interesting questions in telehealth that need to be answered, and we hopefully be able to provide those answers.
And then if I'm going to elaborate on what Hernan just said, and also look at the question about one-to-one for education, because I think we want to foreshadow what we're going to release on April 28th. But let me also just comment with respect to the question about the pattern of telehealth for residents in publicly subsidized housing. For more than a decade, the unique situation of residents in publicly subsidized housing has been a priority of the California Emerging Technology Fund. And we have worked with affordable housing leaders, both those that are on the government side for housing authorities, generally supported and funded through the Housing and Urban Development Department of the US government, and the nonprofit affordable housing organizations that have a variety of subsidies, used to be redevelopment grants, tax allocation credits tax credits from the federal and state government. And we are sponsoring legislation carried by Assemblymember Mike Gibson, co-authored by Assemblymember Wendy Carrillo, that says it's a policy of the state of California to get all residents in publicly subsidized housing, so that's either government housing authorities or nonprofit housing organizations, online with digital proficiency, digital literacy, and with a device that is appropriate to that household. If that household has students, obviously they need a device that is not only a smartphone, it needs to have a keyboard, etc. Now, let me further say, we're always astounded that there is no public agency who has a complete inventory of all of the complexes that are publicly supported. It seems absurd, but it was CETF when now Senator Steve Bradford, he was in the Assembly in 2013 when the first legislation was put through that we sponsored to provide some funding to get people connected and online who live in publicly subsidized housing. Not the Treasurer's Office, who has the tax credit allocation committee for state and federal tax credits, not the Department of Housing and Community Development, not HUD. No one has a complete list. We generate it by gathering data from HUD, the Treasurer's Office, and then we go directly out to all the housing authorities and ask them to provide information. So in sponsoring this, I and my colleagues, Raquel Sinat, Cesar Salvador Mott from the New Start Housing Organization, we have now gathered what we think is the best list, because it's like the only integrated list. There are 5,600 plus publicly subsidized housing complexes. I have reviewed every one of them. We know where they're at. We have their addresses, and we're prepared to go out and ask the kind of questions that you want. And it'll be easier to track their experiences once we get AB 1425 passed, because we'll get them all online. So if this is an issue of concern to you, I just gave you a big pitch to support AB 1425 by Gibson and Carrillo. And now the question to the education, Hernan, one-to-one, you might want to address the data of how we've continued to drop from 18% to 10% to 6% of those who are online that are underconnected, because it's directly related to the school-based strategies.
Yes, I believe if I interpret the question is about digital literacy and particularly for older adults. We did so for the first,
Okay.
I believe for the first time, maybe
That's
Sonny correct me, but for the first time we did introduce a battery of digital literacy questions. And those will be in the third report. The third report will come a week after from, so not following week is telehealth and telework, and then it's the report on education and broadband, and that will have some of the data on digital literacy. We did not ask, this is a good question again, we could ask later, a good question. We did not ask whether there was a preference for one-to-one versus group. I could say that there are a lot of groups working on digital literacy for adults in particular. I know it's a very active area of research and advocacy. But again, we did not ask a specific preference, but we do have some data that will be released that gives you a sense of basically what are the differences in digital literacy by age group. And it'll be interesting to see them because and again, this is I'm guessing here because we haven't delved into this data, that because of the pandemic has really created a huge incentive for a lot of older adults to be online and be more comfortable and engage. In a way, it did it by forcing a lot of us to learn new skills. We learned how to teach online. We didn't know how to do that, and I hope we did a decent job. So I think with all those new skills, I think will be interesting to see how they change. But in particular, I think older adults who are most impacted by the pandemic in terms of quarantine needs, it will be interesting to see whether that's in some way closing that digital literacy gap with other age groups.
And yes, you're right. Diane's question is in terms of older adults. I earlier responded to Karina in that we have what we know are what are called crosstabs. So we have those respondents by age groups. We have those that are responding in terms of what devices they have. And then, as Hernan said, the question was also asked essentially, what functions are you able to perform using a device? Now, those all can be lined up. We can look at the intersection of those responders to determine essentially direction. Once you do a slice and dice that goes down that far on crosstabs, the margin of error, or what is called the confidence level, begins to deteriorate. We can get some insights, but it's not the high confidence level that we're looking for. But of course, Diane and Karina, partners in care, know it has, and we do too, from all age groups, one-to-one training, and that a doctor, the resident, or the individual, the household who's going to actually use the technology needs to have a device in order to be able to learn and to practice. And that's going to be essential for telehealth going forward.
I think those are all the questions we have, Sonny.
Well, I do want to thank everybody for participating, and we consider everyone who was part of the fact-finding listing conferences, all of you who have joined today, as part of a brain trust and a group that we can continue to come back to and plan to. So we appreciate, we hope your good graces to be responsive when we reach out, and we've already gotten through the chat and the exchange, some really good feedback and input for the future. We do think that together we need to have a continuing conversation. We want to express the group sentiment for public policy now, and that's what Leticia and Barb said at the very beginning, for a letter regarding policy that hits on those three major actions that can be reinforced to policymakers and regulators. And then Trong talked about the AB 32, that we want to have more of a conversation about how to get as much information sooner rather than later. And as then June said, the need to think about how to institutionalize telehealth. And then we need to stay the course, as we heard from Lewis, on robust investments for ubiquitous broadband for the infrastructure, and then also for the ability to use that infrastructure. And to do that, everybody needs to have a device and know how to use it. And the price of healthcare, of the internet connection, has to be affordable. So rolling up the connectivity and the devices into programs such as healthcare, or into Medi-Cal, or into Medicare, has to be part of our discussion, just as we have that discussion about devices and affordability needing to go hand in hand to get all students online, or to get everyone who's in workforce training online. So with that, we appreciate your participation and look for the letter that we will circulate, and invite your signature to communicate to all our representatives in Sacramento and Washington. Thank you, everyone.
Thanks, Sunny.
Bye-bye.